right, in the trenches. Today we're going to talk about calcium. Hypocalcemia. The key with this is understanding physiology. And there are really two arms to calcium. Vitamin D and parathormone. So when we take in calcium, we absorb it at the duodenum. About 35% is absorbed. And let's say you take in a gram of calcium a day. The average diet might be a little less than that. 35% of it will be absorbed in the duodenum. In the colon, you'll put another 150 cc's, 200 cc's, it'll be secreted in the stool. Basically, in the urine you have like 50 to 150 milligrams per 24 hours. That's normal calcium. Okay, so vitamin D, you have vitamin D and you get it from sunlight, or you could get it from certain foods like salty fish, not as much in the diet, more sunlight exposure, and you convert it to vitamin D3. It goes to the liver and you have 25 hydroxy D3, and then it goes to the kidney and you have the enzyme 1-alpha hydroxylase, and that causes 125 dihydroxy vitamin D3. This is the active form. This is about 1/10 as active as this. Now that'll do two things. Active vitamin D, okay, will increase absorption of calcium and phosphate from the GI tract, and it mobilizes calcium and phosphorus from the bone. That's what vitamin D does, okay? Parathormone, okay? Parathormone works on three things. It increases the enzyme 125 dihydroxy vitamin D, increased production of that. And really the stimulus of this are parathormone and a low phosphorus stimulate 125 dihydroxy vitamin D3. So it'll do that, it'll mobilize calcium from the bone. And then it has its renal effects. Renal effects of the proximal and the distal tubule. The proximal tubule will decrease the resorption of phosphorus, bicarb, sodium, and calcium. And then at the distal tubule, it'll work real hard and it will resorb calcium. Okay, so you have a patient, say their calcium drops for whatever reason, your PTH released from the parathyroid gland. It's going to increase 125 dihydroxy vitamin D3. You'll increase calcium in the gut to compensate. You'll mobilize calcium from the bone. It's going to directly affect the bone, and there's also going to resorb calcium from the distal convoluted tubule. That's how PTH and vitamin D work, and they're the backbone. They're the backbone of physiology. Okay, now, somebody is a high calcium, I may have talked about it. What do you think of? This is pneumonic, and there are other things that do it, but I learned this as a resident, Pam Schmidt. Parathyroid, adrenal insufficiency, malignancy, sarcoid myeloma, mobilization, vitamin D toxicity, thyrotoxicosis. There are other things that do this. But the two major causes of hypercalcemia are primary hyperparathyroidism and malignancy. with primary hyperparathyroidism being the most common. And you're going to get a PTH level on these patients. And if it's elevated and the calcium's elevated, you probably have a diagnosis. On a subset of patients have an increased PTH and normal calcium. That's called normal calcemic hyperparathyroidism. And there's some patients who have hypercalcemia and their PTH is not elevated, but it's higher than it should be, and that's probably hyperparathyroidism also. That's called non-hormonal. And these people, and the younger the person, the more you have to be worried about renal toxicity and stones, and also osteoporosis. Okay, malignancy, there's 4 mechanisms. There's something called humoral hypercalcemia malignancy, more common with squamous cell cancers. So squamous cell lung cancer, head and neck cancer, and esophageal cancer. They cause squamous cell, often seen in drinkers and smokers. And also GU tumors like renal and ovarian. Then multiple myeloma does it. We used to call this osteoclastic activating factor. It involves a rank ligand, and it causes mobilization of calcium from bone. And it's part of the defining myeloma criteria, CRAB, where the C is calcium. Okay. Then also, you get a direct bone mets, like with lung and breast cancer, which could cause calcium to leak out. And then subset of patients with lymphoma, Hodgkin's more than non-Hodgkin's, secrete 1-alpha hydroxylase and you get increased vitamin D. Those are the 4 mechanisms. Now there are other causes of hypercalcemia that you have to think of. The granulomatous diseases, where the granulomas secrete the enzyme 1-alpha hydroxylase and you get increased vitamin D. The classic one being sarcoid. Sarcoid, often before the hypercalcemia, you get hypercalciuria and you get kidney stones, but you get hypercalcemia. You can see it with TB, fungal infections. I had a patient who had it from silicone injections in his buttocks. So you could see this. And that's the next thing. Hyperthyroidism, once in a while, if you're thyrotoxic, release calcium from bone. Medications, most common medicine are thiazides. And often, a lot of these patients have underlying hyperparathyroidism and lithium. Taken back, there's another condition called familial hypercalcemia, hypocalciuria, where the PTH receptor is reset. Okay, and PTH is released with lower levels of calcium and it elevates calcium. Kind of thiazides cause a picture like this. There are other causes, but these are the causes that you to think about. Immobilization, especially in someone with rapid bone turnover, like an adolescent or a patient with Paget's disease. Adrenal insufficiency is unusual. Theoretically, you have to do a history. They could have milk alkali syndrome, which I've seen in my career multiple times, or vitamin D toxicity, or rarely vitamin A toxicity. That's hypercalcemia. Now, if someone has an increased PTH, there are certain clues, and it's going to cause a decreased phosphorus and decreased bicarb, and they're actually going to have like a proximal RTA type 2, and they have a low phosphorus. And people with humoral hypercalcemia lipomalignancy will have the same thing. And with that, you're going to measure something called a PTH-related protein, which is elevated with humoral hypercalcemia malignancy. If you're diagnosing myeloma, then you're going to get serum free light chains and serum protein and immune electrophoresis. And I think I'm just going to stop. That's all I want to say now.